Hi everyone and welcome to the Asia Pacific Glaucoma Society Young Glaucoma Experts Program. I'm Colin Clement and I'm your moderator and one of the mentors for today's APGS activity. The Society endeavours to foster an environment where our junior colleagues can benefit from the expertise and experience of the professors invited to participate as mentors. This is meant to help develop and assist with your clinical research and clinical practice. APGS welcomes everyone to become a member of the Society. It's open to glaucoma specialists, ophthalmologists, researchers, trainees, specialists, associates, and companies with affiliation in glaucoma. There are many reasons to join APGS, and on screen are just a few items which we can share with you. You can register as a member by scanning the QR code. All APGS members gain access to all recordings of previous APGS joint symposiums, masterclasses, and webinars. One final disclaimer: presentations are intended for educational purposes and do not replace independent professional judgment. After the conclusion of the event, you will receive a short feedback survey, and we'd really appreciate it if you can take a moment to complete it. So I'd like to start today's webinar by thanking my fellow mentor and introducing Professor Leon Au. Leon's a consultant ophthalmic surgeon specialising in glaucoma and cornea. He graduated from the University of Nottingham in 1998 with an ophthalmology prize for that year. He completed 8 years of general ophthalmology training in Nottingham and Manchester before undertaking separate subspecialty training fellowships in cornea, glaucoma and refractive surgery. He's been a dual specialty consultant in the Manchester Royal Eye Hospital since February 2009, and he's an international leader in the field of surgeries and is involved in many clinical trials. Now, before I introduce the first speaker, I just want to remind you that if anyone in the audience has questions, please key it into the comments section. All the case presenters and mentors will participate in the question and answer sessions scheduled to occur between presentations and at the end of this webinar. So now I would very much like to introduce our first YGE presenter, and he's going to present 2 cases for us. I'm pleased to introduce Dr. Poemen, who is the Assistant Professor at the Chinese University of Hong Kong, Department of Ophthalmology and Visual Sciences. He is also the Glaucoma Coordinator of the CUHK Ophthalmic Microsurgical Training Program. Internationally, he's a member of the World Glaucoma Association Associate Advisory Board, a committee member of the Global Outreach Committee of WGA. And he is the first certifier trainer of iStent, Zen Gel Implant, and Microshunt in Hong Kong. He's also a section leader and section author for the 4th edition of the APGS guidelines. Now, Dr. Chen will be conducting a poll during his presentation, and you can participate in both of these, either by scanning the QR code shown on the slide deck, or by going to www.slido, that's slido.com, and keying in hashtag YGEP23.
So thank you very much for the kind introduction. So we're going to talk about some cases concerning the MIGS today. So let me share the slides. So these are my slides. So I'm Poemen Chan from Chinese University of Hong Kong, and thank you very much for having me today. And these are my financial disclosure. Hopefully these cases would bring about some of the interesting points concerning MIGS procedure. Now, our first patient is a 70-year-old woman with a right-only eye, advanced glaucoma 2 for the right eye. She has a medical history of hypertension and diabetes on dietary control. The ophthalmic history, she has bilateral high myopia with myopic maculopathy, and cataract extractions were performed in before the year 2000. Now, in February 2016, she was referred from a private ophthalmologist for the management of primary open-angle glaucoma. The visual acuity on the right eye is 0.5. For the left eye is hand movement, and as you can see, the pressure is not very well controlled. Now, for the right eye, we don't know about the baseline intraocular pressure, but we know that she was already on COSOP and also Taflotan, cup disc ratio of 0.7, 0.5, 0.95. So we know that we have to do something about the intraocular pressure. Well, we gave her various different options, but then she wanted to be more conservative. So we attempt SLT for the right eye twice in December 2016 and January 2017. However, the intraocular pressure was poorly controlled. In fact, after the second SLT, intraocular pressure raised up to 47. So we have to do a trabeculectomy for the right eye. Initially, it was quite good. Intraocular pressure was 8 millimeters mercury without any complications. It was trace amount of hyphema. However, at day 4, intraocular pressure shoots up to 53 millimeters mercury because there was a blocked blood clot in the internal ostium. So AC washout was performed with black revisions. Post-op intraocular pressure was 8 millimeters mercury. Now, just for the left eye, just like to talk about the left eye a little bit. Intraocular pressure was poorly controlled, however, not symptomatic. Patient preferred a more conservative management, so we did repeated micropulse for the left eye. Now, coming back to the right eye, initially it was all right for the right eye for about 3 years. However, the pressure, intraocular pressure was going up to 38 millimeters mercury in August 2020 with a shallow cystic bleb. We started topical medication. It was maintained at around 15 to 19. Now, SL, again, she doesn't really want to have very invasive surgery. So SLT, again, we tried that. It works about for 2 months, but then there was a raised intraocular pressure again. And then again, she wanted to be more conservative. We try our best to be as conservative as possible. We tried 4 needlings. Didn't quite work, really. The last needling, in fact, we noticed that there are some bleb leakage, and the pressure was about 13. And when we put in the bandage contact lens and the bleb stopped leaking, the bleb doesn't work. So the intraocular pressure went up to 30 again, and she was on oral acetazolamide. Visual acuity was dropping. So from 0.4 all the way down to less than 0.1. So the patient came to see me the first time when I saw this heavily scarred down bleb, failed multiple needling attempt, but the bleb was still leaking. So, and also there's some bleb leak. So what would you do? These are the choices here. And so let's go for the voting. So would you prefer do the needling again, do the trabeculectomy, glaucoma drainage device, implantations, micropulse or a G-probe, or doing a MIGS procedure? So we have the result now, have we? Right. Let's see. Right. Right. So we are we all right? Have we finished with the voting? Right. So in fact, a lot of you would go for trabeculectomy. But again, as I said, patient has a bad experience about trabeculectomy, so she really wants to do a MIGS procedure. The options were discussed. So patient opted for gel stent implantation. So this is what happened in the operating theater. I was sitting on the temporal side of the patients, and you can see that the bleb is very cystic, very injected. Actually, there was some leakage around the nasal side. So the usual 9 millimeters away, 9 to 8 millimeters away from the limbus, injection of 0.1 cc of MMC of a concentration of 0.2 milligrams per cc. Making sure that we don't try not to leak any of the MMC out. And afterward, we push the injections up, make it flat so that we can demarcate the site where we want to implant the Stent 3 millimeters away from the limbus. I try to mark a little bit more just to make sure that I know where I am. and I tend to flush the sand gel stent. It's my routine nowadays with a 30 gauge needle, cannula, beg your pardon. So paracentesis, so that I can get my instrument into anchor into the eye. As you can see, I'm approaching the, I'm doing the sand gel injection now, and you would just be able to see, sorry about the, I think I was accommodating during the procedure. Now, you would be able to see the tips coming out from one of the marking, or near one of the marking. There we go. The tip is coming out, and then try to turn 90 degrees. I think I did. And then I push the sand out, and you will see that the needle will slowly retract as it goes along. It was a slight sudden giving way, but fortunately I was okay. I get away from that. So you can see that the conch is actually quite injected. I was trying to show that the sand gel stand is actually there. Not very clear with the Mori here, but it was there, I assure you. I can show you some, yeah, there we go. And of course, I test the mobility of the sand. It doesn't seem to be very mobile, and I don't think there was much aqueous coming out. So I have to do a primary needling right away with 30 gauge needle. So you will see that once I push the tenon away, the bleb will form immediately in front of you. There. So the guess was right. You know, there was some tenon blocking the sand gel. So go above and below the sand, just free it up, just making sure that it's mobile. I cut away the part where I test the mobility of the sand, which will be shown later on in other videos. And I try not to overdo it. I don't want to make too much bleeding. So remove the helons and close the wound. Pressure was okay. So this is the photo. Oops, sorry. This is a clinical photo, slit line photo 3 weeks after the procedure. You can see the sand is actually in situ with bleb forming and a supranasal aspect, actually sort of bypassing the original trabeculectomy. So the pressure is actually going okay. We're marching on towards the second month now. The pressure is actually 14 without any medications. Slightly posterior implantation of the sand, but it's sitting happily over there. So at the moment, still working okay. Just before I finish this case, just like to share with you another case very briefly. Many years ago, we've done it in 2019, I think. A 57-year-old man with advanced glaucoma on both eyes. Right side trabeculectomy was actually okay, but the left eye we did repeated needling without any success. So, well, I borrowed this photo from the web, but this is pretty much what it looks like. And what we're trying to do is to avoid the rectus muscle. I want to direct the aqueous flow as posterior as possible. And this is the internal ostium of the bleb. There's no blockage, but it's just the conjunctival was scarring sort of intransigently. So you can see that this is a visual field 10-2, so very advanced glaucoma. So we did insertions, implantation of the sand gel. Again, it's slightly more posterior. Intraocular pressure was well maintained. I've just seen a patient a month ago. He was actually okay with intraocular pressure of 15, now on 2 eye drops. So he's happy about it at the moment. So this is it for this part of the case. Thank you very much.
Thank you, Poemen. That's a very interesting case. I'd like to invite Leon to make a few comments or ask some questions.
Thanks.
Yeah, no. Comment. Hello, Leon.
Hi. It's a great case, and I take, when I looked at the polling, I think most people would go for a tube. And I suppose I was just curious in terms of your discussion. Obviously, you mentioned a fair bit about the patient choice, or patients doesn't really want anything too invasive. And I have a strong view about letting patients choose in terms of what's best for them. And I always find that, that they of course will choose whatever you advise them generally. So I was wondering about that discussion you've had with the patient in terms of a tube was pretty obvious that will be high on your list. And how did that consultation go with the patient?
Yes, you're quite right. If when we as surgeons have been doing the tubes for so many times, we feel that the tube is actually very safe, but sort of safe, but in the patient perspective, when we talk about it, we have to discuss about how we did the procedure and all that. And obviously, it's a little bit of bias because you have to mention about opening up the conch, and the tube is about that sort of size, and you have to shove this horrible thing into the eye. And some of them might not be terribly comfortable about it. And I suppose for this particular patient, she's not very keen about the tube. And for me, of course, I tend to go for the tube too. But then my thinking was, if I can try again for the supranasal side. Now, if that doesn't work, at least I still got the supratemporal side where I can do the tube there. That was the thought at the time.
And I think that's certainly.
I don't think micropulse works for her, and she doesn't think so either.
I mean, I think I can see that it seems like a logical approach. I think certainly for me, when that situation, that like you said, when the patient doesn't want a lot of invasive surgery, and that's always an interesting discussion but also patients already had, I can count 5 or 6 procedures, including multiple needling. Then you're kind of thinking, okay, I offer you a tube that I think this is going to be it, full stop, in terms of the likelihood of qualifying a complete success compared to possibly a Zen in an eye that's a multiple procedure and you couldn't address the leak neither. That was my only other worry, that if you do a tube, you will open it up, you will close the trap, and you will address all the problem in one go. And I presume that leak just stopped because the aqueous is draining somewhere else. Is that correct? Or also you ran the risk of a bit of a hypotony with the Zen?
Yes, indeed. Yes. Yeah. So every time you're quite right. The Zen somehow sort of bypass all the aqueous away from the leakage. So the original trabeculectomy doesn't really quite work. And you're quite right in saying that in fact the original site of the trabeculectomy is actually slightly towards the temporal side.
Yeah.
And I did also worried about, if I do another incision over there, it might cause a leakage. And it was also a revised flap as well. So, I was a bit worried about, what the mobility of the conch, whether I still got enough room to put in a tube.
I very much agree with Leon's point that the way we present information will influence patients' decision making, because this patient obviously felt that they're getting a fairly minimal procedure, but in reality they are getting an invasive procedure that is bleb dependent, and in some respects it's not so much different to having a tube put in, right? My one comment I wanted to make is, this particular case where you've got an only eye and a myope that's had a previous trabeculectomy which has failed and there's leaking, in terms of what the next treatment should be, it's a fairly thin area in terms of evidence. So your decision making is not really based on clinical trial data. It's based on what makes sense and what's worked in your hands in the past. I just had a couple of questions about the case. One was, what would you do if the bleb was more superior or more nasal? Would you try a Zen in a different location, or would you offer a different option altogether?
I probably won't go for a Zen if you're talking about superior, a more superior, more 12 o'clock implantation. First, I think for me, I think it's quite difficult for me to get there. I tend to go from the temporal side, and going right up to 12 o'clock is a little bit difficult. And as you can see in the tube, the Zen actually tend to drain more posteriorly, and I always worry about the rectus muscle maybe on the way. I tend to do my trabeculectomy more on the supranasal side anyway, just to avoid the rectus muscle, so that hopefully the aqueous can go more posterior.
Yep.
So I would tend to think about something else.
Yep.
if it's more nasal originally.
And the other question, forget me if I recall this wrong, but you did the Zen in 2023 for this case, is that right? It was done this year?
Yes,
was the Zen put in with you? Yeah. And
yeah, we did it
in
either in.
Yep. So, and my recollection is that the trabeculectomy initially was working, and then it subsequently failed. So,
sorry, I beg your pardon. Sort of.
So the primary trabeculectomy was originally working, and then subsequently failed. Correct. So
Yes,
my question is, have you considered that you might get a similar outcome with the Zen working for a period of time and then failing, particularly given that it's a second conjunctival-based procedure?
Yes, I have that concern too. I have that concern too. She was a bit worried about the needling because there was a leak on the last one.
Mm-hmm.
So she knows that after the Zen implantation, she might need more needling.
Yep.
But then, she, after much discussion, she acknowledged that. So that's okay. And she's a 70-year-old. We hope that it would last for another 10 years or so. Yes, Leon?
Yeah, no, I would agree with Colin that we're very evidence light, and your decision making is based on your last 5 cases. If you did 5 really good Zen, you're going to keep doing it. If the last 5 didn't work, then you probably wouldn't. So I agree, it's very experience based. But whatever evidence we look at, so I suppose if you spin it the other way around, I can say that I didn't see the field. I don't know how low a target pressure we need to go. But whichever Zen series you look at, we are sitting around about 14, 15. And that's roughly what we tend to get. Yes, she's had previous failed trabeculectomy with multiple needling. So if you look at whatever little bit of evidence we have, if you draw the TDT trial, then you are likely to be looking at a tube over a trabeculectomy. And I don't think there's any doubt that a Zen implant is not as powerful as a trabeculectomy. And whichever series you look at from a Zen, you have all the way up to 50% needling rate. So on this lady who's had multiple needling with an eye that's quite red, then I certainly Zen has been done in this situation in patient who is adamant he doesn't want a tube. And I think, I don't have your patient, so some people just don't want a tube because when you mention there's a chance that you may get a droopy lid and double vision, the diplopia is the big thing, then you won't get it anywhere else. So I can see why a Zen could be done, but you're right that the percentage shot would be a tube. That is much more likely to last. You can address the leak and it's done. And evidence-wise, if you look at what half of the glaucoma specialists in the world will back you up, probably they will back a tube over a Zen. But I kind of hope that your Zen will last a good 10 years and that will be a good mixed outcome.
Thanks, Leon.
Yeah, you're quite right.
Yep. So I think we're starting to get a few questions coming on the comments, but we might move on to the next presentation and come back to those. So I'd like to introduce now Dr. Chung Tun Wang, who's ophthalmologist and glaucoma surgeon at the Pantai Hospital, Ipoh, Malaysia. He graduated in medicine and completed his Master of Medicine in Ophthalmology from the University of Sains, Malaysia. He did further glaucoma fellowship studies at the Clinique de Montchoisy, Lausanne, Switzerland, and received a certificate of completion for fellowship training in glaucoma from the Ministry of Health Malaysia. He's a recipient of the Asia Pacific Academy of Ophthalmology International Fellowship Program at Osaka University Hospital, Japan, and his special interests are ophthalmic photography, complex cataract and glaucoma surgery, and he's involved in ophthalmology-related research and part of the editorial team for the Malaysian Journal of Ophthalmology. Thanks, Chung Tan.
Welcome to APGS Young Glaucoma Expert Program. I'm Chung from Pantai Hospital, Ipoh, Malaysia. I would like to share with today a case of MIGS in management of juvenile open-angle glaucoma. I have no conflicts of interest in this presentation. As we know that juvenile open-angle glaucoma has the earliest onset with higher IOP, more severe visual loss, as well as usually resistant to medical therapy compared to adult onset open-angle glaucoma. I have a case of 20 years old male with young hypertension, referred from district hospital for bilateral high intraocular pressure. He was treated as an acute angle closure glaucoma with a laser done bilaterally. He's on maximal topical anti-glaucoma medication, including acetazolamide to control his intraocular pressure. On the affected left eye, the vision during presentation is 660 with a deep anterior chamber, wide IOP fluctuation between 40 to 60, and the cup-disk ratio is 0.9 in view to hazy view due to corneal edema. The visual field shows that the left side, the tunnel vision with a macular split. The objective of the treatment is to reduce the intraocular pressure of the left eye. In view of macular split, there's a high risk of whiteout syndrome. Now, what are the options available? The objective is to reduce the intraocular pressure at the same time to reduce the risk of whiteout syndrome. Conventionally, we have traps, we have tubes, we have Zen, and even we have laser procedure. So let's look at each of them. What are the pros and cons? For trap, we're able to see this effectively, the IOP will be reduced. However, the risk of hypertonic, especially the initial first to second week, is high, especially in young patients, and we have difficulties to titrate the intraocular pressure intraoperatively. Postoperatively, we may need some adjuvant interventions such as injection of viscoelastic into the anterior chamber to maintain the intraocular pressure. And because of reduced IOP, there's a risk of ocular decompressive retinopathy initial post-op. The second option is to go for valve tubes. However, we know that the valve tubes may have some encapsulation as well as early as the first months. However, the other option is we're able to go for non-valve tubes. We're quite sure that the long-term outcome and sustainability of pressure is quite good. However, the pressure is involatile initially. It can be hyper, it can be hypo as well. Other option at this moment, we have Zen. We know that the procedure is fast, minimum invasive, we're able to reserve the site and allow subsequent glaucoma surgery or intervention, especially in this case, young patient. Be aware that it also higher needling rate in this type of case. If you're not going for surgery, we have to go for cyclophotocoagulation. But bear in mind that the IOP reduction is unpredictable in this type of procedure. Now, besides from reduced IOP, we need to avoid the risk of wipeout. So we try to avoid wide IOP fluctuation intra and post-operatively. We choose Zen. This is a long-term plan and short-term plan for this patient. Either we go for Zen or we go for valve tubes as a first line. If in case Zen it failed, we're still able to go to valve tube, and both fail again, we're able to go for non-valve tube in the future. Decided for Zen, the IOP post-op is 12, vision 636, 624, quite good result. 1 week post-op, we're able to see the fundus. We're able to avoid a serious ocular decompression retinopathy, but there's still some mild venous toxicity because of decompression effect. As expected, the IOP increased to 30 1 month, and we choose to go in for revision of Zen instead of needling. Intraoperatively, the tick tenon strongly at higher to the distal end of Zen, which we need to cut it. Immediate post-op, 8, vision 636, best corrected. 4 months while doing these patients, in 6 months vision, feel we're able to maintain the central small island of vision. Intermittently, we inject 5T2 injection to maintain the bleb. However, it only lasts for 1 year, 10 months. It's quite a good duration. Intraoperatively, you can see from video, there's a quite thick tenon, thick fibrosis occur, which is very adherent, very difficult to release. Step by steps, we try to open up, try to release at the same time, try not to injure or truncate fully the whole Zen. We try to release as much as we can as possible. Difficult to see. We try to use this surgical lens to see. You can see centrally yellowish color Zen, and we try to check whether is there any flow by releasing of it. Unfortunately, we don't get any of it. The fluid is actually adjacent fluid. It's not from the Zen at this moment. And finally, we decided to cut it off or truncated the distal end of the Zen. So now we're able to see some fluid, which is flow from distal end. By using the fluorescence, you can see there's sludge oozing out from the distal end, and even can see the whole tube, which is embedded in the center of the fibrous tubular structure. We check again to make sure it's really flow. Using this spondex material, yes, we're quite happy there's a flow. So with that, we maintain the Zen for the second time. However, it only lasts for 4 months. The intraocular pressure increased again. Now it's so short. Now we decide whether we should go for the third revision of Zen or we go for the second surgery. We decided to go for Pau glaucoma implant. So how it lasts on in the future, we need to follow up. Summary for this chronology effect: medical therapy is refractory. We go for Zen, and subsequently 1 month later, we go in for the first revision. In between, 5-year subconch injection, and 1 year, 10 months later, the second revision. And for the second revision, it only sustained for 4 months, and we need to go for the third procedure, which is glaucoma drainage implant. What is next? And what has been known before, we know that a young patient, he has a robust healing process. They require multiple glaucoma surgery in their lifetime, and we need to reserve the site because of that. The surgical IOP reduction is volatile. Probably this is due to probably flexible scleral rigidity and the risk of ocular decompression retinopathy. In our case, we have macular split. We have to avoid risk of whiteout syndrome. In this case, you also learned that the Zen revision, you can't avoidable. We're unable to avoid fibrosis as well. And we need to reserve the site for future surgery if needed. True enough, in this case, 2.5 years plus, we go in for tubes. And we avoid the immediate post-operative hypertonic and decompression retinopathy. Consequently, the IOP control reduction is quite controlled and good. We're able to avoid the whiteout syndrome. Looking forward, we have new device such as PreserFlow, which is the double-sized internal lumens, about 70 micrometer. Where the different materials made the tube cause a different fibrosis, which is SIPS versus porcine collagen-derived gelatin. Let's look at the result in the future. In conclusion, MIGS in management of juvenile open-angle glaucoma has an important role. It's minimum invasive, smaller diameter allowed control IOP reduction. We reserve the site for future surgery if needed. However, each of the case need to be individualized in consideration the pros and cons of each of the case. A special thanks to Dr. Ng as well as Lim as well as any individual who direct or indirectly involved in the management of this case. With that, thank you very much for your kind attention.
Thanks very much, Dr. Chung, for a wonderful presentation. I'll throw it over now to Leon for any comments or questions.
Thanks. There are quite a lot to discuss, actually, and it's a great case. Ironically, for a MIGS webinar, I am going to say that this actually does lend itself to angle-based surgery. Again, very evidence-light, because we are picking very interesting cases, but I think a lot of us anecdotally feel that in juvenile onset glaucoma, in JOAC, angle-based surgery works very well. They have rather abnormal looking trabecular meshwork with iris little strands coming up. And I think we've all had pretty anecdotal success when you remove some of that meshwork, either with a GAT procedure, either with a KDB knife or bent angle needle, even if they're phakic 20-year-olds. So I've had less than a handful of patients where the pressure is sky high. Now, pre-op IOP doesn't matter. Pre-op IOP is high because they've got no outflow, not because they make more fluid, but they respond ridiculously well when we remove the meshwork. So that actually would be the mix of choice for me. I would go in, heal on GV. I would worry about decompression like you have, and I would give them some mannitol pre-op to bring the pressure down. I would decompress the eye as little as I can by filling them back up with heal on GV, and I would open up the nasal angle with a KDB knife. And that would be my actually first mix of choice. Failing that, I would disagree with you that I would go for a trabeculectomy. But then because your field is so bad, then you want a low pressure. And for trap, for me, I feel like all the complication you mentioned is controlled by me. I can tie the suture well. I can put an AC maintainer. While the hypotony, the fluctuation on IOP that you may get with the Zen, you have no way of controlling because you can't control anything really apart from where you put it. So for me, would be a trap. And ultimately you landed up with a POR, which I think is a phenomenal tube. And I bet you many think that would be the last operation this patient would need. There are very few patients, even for JOAG, would end up having 2 or 3 tubes. I mean, there aren't that many patients. 2 or 3 RMET maybe. So, so for me, angle-based surgery, particularly TM removal in JOAG and some of the Uveitis is pretty powerful.
Thanks for your comment, Professor Au.
What do you think, Colin?
Well, I was looking at the case and thinking that it wasn't particularly MIGS. That, you know, there were a number of visits to the theatre over a few year period, opening up conjunctiva, removing scar tissue. It felt very much like very invasive glaucoma surgery. My concern, again, like the other case, there's not a lot of evidence to support using a Zen in this situation. By doing this, you then limit your options with potentially doing a trabeculectomy afterwards because you've already got subconjunctival fibrosis and you increase your risk of a trab failing subsequently. And I'm mindful of the fact that this patient is very young and they've got very extensive disc damage, so they're going to need low pressures over a long period of time if there's any chance of them maintaining their vision. So I would, in this case, I would keep it very traditional, and I agree with Leon, you could try an angle-based procedure and there's not a lot of risk associated with that. But from there, I would do trab and then tube.
Yeah, I think that both cases is the same, right? And I think that you would tend to see for the last 10 years, this explosion of MIGS. And then people would attempt it in some of these absolutely dire cases where deep down, we all think it should be either a trab or a tube. And overall, take it from me for the last 12, 13 years that if the patient needs a trab or tube, they have a trab or tube because the MIGS generally would disappoint you.
Yep.
Very few cases I've gone away with a MIGS thinking, oh, I know, rather than doing what they really need is a trab and a tube. So for anybody who's watching this, who's reasonably young in training, MIGS is great. And we may forget about separating MIGS and non-MIGS. You know, this is new glaucoma surgery, but we must be good at our traps. We must be good at our tubes, and we must lower our complication with our traps. That's why I think that my trap nowadays is quite safe, but it has its downside in terms of the invasiveness. Wipeout is a whole different discussion. I'm not entirely sure I particularly believe it happens that often, and I believe in the control of intraocular pressure. So it wouldn't particularly scare me to do a trap, even though there's such an extensive field. But for me, we must be confident with our trabeculectomy.
I think in cases like this, because you know the patient is at risk of decompression retinopathy and hypotension postoperatively, you would modify your technique to take that into account. So like Leon said, you would do something preoperatively to lower the pressure so that the pressure gradient before and after surgery is lessened. and then you would change your technique so that you had a tight closure initially, and then you titrate in the post-operative period to get a gradual reduction in pressure over time.
Yeah, I
And
understand.
I suppose one of the comment that we've had with Zen implant compared to pressure flow, I mean, some of us in Europe now, I suppose we're part of Europe still, you know, pressure flow has been here, certainly for me, for the last 4 or 5 years. And I think most previous Zen surgeons have completely moved away. And the lumen is not an issue. I don't believe the material is particularly special. Yes, the Zen implant break even when you just look at it. You know, the pressure flow is much more rigid, but ultimately it's the ability to open up the conjunctiva and place your device subtenon. And the ab internal approach by putting a Zen in, sometimes if you don't get it under tenon, you get tangled up with tenon, which is why the needling rate is so high. And I've seen your revision. We've all been there looking at this Zen wrapped up with tenon, don't know how to free that up. We have far less of that with the pressure flow. So when it comes around to your part of the world, I think that you probably will switch over and you see the benefit of the pressure flow.
Yeah, sure. Yeah, thanks for the comment, Prof. Hao.
Oh, Colin's just dropped out. So that does that leave me to it? Would you do anything differently, Dr. Wang, if you go back and do it all over again?
I think at that time, because look at the pressure flow, probably pressure just came to our country this year, so this is something new to us. Yeah. So yeah, at the time when this patient presented to us, at the time, you know, we still have Zen. At the time, we don't have pressure flow. Yeah, I think probably as you mentioned, yeah, we have a few bad experience on track, especially a young patient. You know, so that's why thinking of probably using this tube with a persistent, consistent diameter, probably it helps to, you know, maintain the pressure, especially the immediate post-op period, the first and second week. Yeah, that's what we are thinking at the time.
Yeah, no, I think trabeculectomy, for me, well, I mean, we deal with an AC maintainer, so then the AC is always maintained, and then we have the releasable sutures, so then we can tie it really tight and take it down slowly. And I think that whole Morpheus safe surgery system really changed the way how trabeculectomy, not the outcome, but the safety and the adjustability. And I think ultimately throughout the whole glaucoma procedure, filtration surgery in particular, you look at the Zen, look at the pressure flow, the trap and tube, valve and non-valve, it's always about flow control. If you can control flow, then reduce scarring of mitomycin C, then our safety profile goes up and our efficacy increase. And part of the problem with the Zen is that you have very little control of flow. So the pressure tends to be low. Hypotony rate for the Zen implant, ironically, is a bit higher than the pressure flow because the Zen tends to leak around the exit. There's paratube leak to begin with. So in a young patient, often we do get a bit of hypotony for the first week or two. And then the lumen, it offers you restriction, so offers you resistance. So then that's why the pressure is always around about 14, 15, rather than trabeculectomy. You can get lower because you can reduce the resistance by removing the suture. So when people always say that Zen implant is safer than a trabeculectomy, and I suppose we do have the question that what you mean by safer. I think wipeout will be unmeasurable between the two procedures because, you know, it's such a rare phenomenon. Hypotony rate for me is higher with the Zen than a trabeculectomy in general.
I see.
In general, I just feel like I've got more control, rightly or wrongly. And I think ability to open the conch and open the tenon is a big deal when you're able to create drainage. And I'm glad the fact that you picked the poor tube, which I think is the best of two tubes combined. You know, this is the benefit of a valve tube and the efficacy on a non-valve. Hello, Colin.
Agree.
Hi, sorry, my computer went flat. Now I think Dr. Chan has another presentation for us.
Oh, okay. Right?
Sorry, Dr. Chen, you're muted.
All right, so thank you very much. Sorry about that. Let me go back to the very beginning. Is the screen sharing? Yes.
Yes, the
So you can
screen.
see
We
my
can
slide.
see
Okay,
the
so-
screen.
Right, so our third patient is 61-year-old male, right eye recurrent and chronic uveitis, maximum intraocular pressure to 30 millimeters mercury on full dose medication and also oral acetazolamide. Now, in May 2018, he underwent a combined phaco trap, a brief episode of hypotony for the first week, but then it was spontaneously resolved, and intraocular pressure around 10 to 13, has been drug-free for 4 months. But then he has to slowly resume the medication over the next 8 months because of the slowly rising intraocular pressure. There was no uveitis at the time. Now, in January, starting from 2019 to March 2020, he had 3 needlings, approximately 3 needling in each year. Hypotony for the first 2, for the first week, but resumed medications. But it was fine afterward. Then he resumed medications when intraocular pressure went up to 21. Now, for his last needling, it didn't quite work. He was originally 23 millimeters mercury on 3 eye drops, but after the needling, it was 21 millimeters mercury. And so after 1 month, he requires another 3 medication again, and also oral medication. Intraocular pressure was then maintained at around 18 to 20. Cup-disc ratio is 0.9, quite severe visual field defect, and also affecting the central visual field now. The patient does not want needling anymore, and is also reluctant for micropulse. The choices were to do a retroclectomy, glaucoma drainage device, and stent gel implantations. Now, whilst I was trying to discuss with the patients, he went out and did a stent gel implantation by someone else. So in the first day, the intraocular pressure was all right, and has been on no medication for the next 2 months until at the second month, the intraocular pressure went up to about 25, but he doesn't want any medication. Now, I'm afraid I don't have any clinical photos here, but this is just animations of what happened. So we see a scar down breadth on the 12 o'clock region, and there's minimal bleb formations around the stent gel, and gonioscopically, I can see that the stent gel is actually wrapping around the iris, and also the stent gel maybe penetrating the iris. So the choices are here. So let's go for some votes. So choice A is trabeculectomy in another site. You can also consider glaucoma drainage device implantation, needling of the previous bleb, and needling of the stent gel stent, or the bleb revision of the stent gel stent. Right. Right. So seems like we have a number of choices here. After much discussion with the patients, he would like to go for the. After much discussion with the patients, he would like to go for the stent revision or the stent needling first before considering a tube shunt procedure. So this is the video. So you can see the. I'm sorry about the view; it's not very clear, but you can see that the first short stent wrap around by the peripheral iris. This is a Mori gonioscopy. So I'm sitting at the temporal aspect. I inject some Helon at the site where I'm going to do my manipulations. And again, I use an armored micro grasper, try to free up the sand over there. I'm sorry about this outside of viewers, but eventually you will be able to see that the Sengel stent is actually freed up from the blocked iris. So what we saw is the iris was wrapped around the stent, and you can now see that the stent is there now. Is freed up. It's actually supposed to be quite long, but it was hiding underneath the iris. So proximal then is now freed. So what I did is I used an anterior retractor to create an iridotomy because I worried that the proximal end would be blocked by the iris again. So high vacuum, a slow cut for the anterior retractor. You can see I just created a hole there, very small one. So the anterior chamber is slightly collapsed now, but later on you will see that the hole is actually fairly good. It's just outside, it's just proximal to the opening of the proximal end. So that's the hole. So the stent is actually facing that iridotomy now. Iridotomy there, and I then go to the superior, check, and there is not much drainage. So I go for needling for the distal part of the stent. Again, a 30 gauge needle. You see a gush of fluid. You already see some fluid coming out once we push the tissue away. A little bit of bleeding. Go above the stent, and we do that again. So the bleb is forming, and we don't want to overdo the needling. You can see that the stent is actually now mobile. Just another video showing you, this is not a different patient. So this is a patient we did the needling for the bleb, and you can see the stent is actually mobile, and you can see fluid coming out from the stent. So if we push the stent to one side, you can see the fluid gushing out, and also the other side. I have no financial interest with this instrument, so I just named this instrument to tell you that what instrument I was using. So you can see the fluid coming out, and the rest of the videos is pretty much the same. So this is it for this patient. Patient currently, I forgot about the next slide, which I then put in. Patients had done the surgery so far, and the pressure has been maintaining without any medication. So at the moment, he's not on any medications, and currently the pressure is 13 millimeters mercury. The last time I saw him, which was again a month ago. Thank you.
Great, thanks, Dr. Chan. So that brings us to the end of our case presentations. We're going to open up for general discussion. I guess I'll start by asking Leon if he has any comments or questions about this case.
I think that's very well done, that one. But the joy is always revise someone else's surgery.
Thank you.
That's always the joy. And, I think a lot of people would probably have given up on that Zen, particularly on the internal bit of it. A word for everybody watching that for a drainage device like a Zen or PRESERFLO or even a tube, if your pressure has been 12, and suddenly go up to 40, then your device is blocked. Bleb failure doesn't shoot up so high. So when you suddenly get somebody come back with a very high pressure, then look very hard. And people don't often put a gonio, especially with the Zen, because it's so tucked up. And this is a classic, right? Uveitic, the iris inflammation, they're sticky, you can get PAS. So the only worry that I have doing what you did was I would worry about a uveitic flare-up by manipulating the iris. But fortunately, if your patient is well controlled, lots of steroid before, and I think you did a great thing to revise that. And if someone else has put a Zen in, then yes, I would revise that. I would probably go back and wonder why our needling of the trap didn't work. And then I don't know whether that was done in theater, and I would always needle with mitomycin C nowadays. And I think that might make a difference in terms of our needling success. And then, of course, someone would pick a tube. And we'll go back to the same question in terms of what the patient would like. Micropulse would never be a goal for me in a uveitic. I would never do a ciliary body-based treatment. And then, so the toss-up between, and ironically, we published our Zen implant in uveitics, and they seem to work quite well, probably because the uveitic don't have to drain that much. They don't produce that much aqueous. So the longevity, I can't tell you, but certainly the IOP lowering can be quite impressive. But it's about what patient choose and how you present it. For me, I generally will avoid like patient choose this, and I would probably present them what I think is right, and then convince them that way, based on what I know and what works in my hand.
Thank you. I mean, I wouldn't put a Zen there for uveitic personally, but since it's already there, then I may as well try to revise it.
Ironically, we did a fair bit of Zen in the uveitics because we have a lot of uveitics coming in with a pressure of 40 and 50 on a Friday afternoon. That's where my clinic is. And I'm sick and tired of staying behind and putting a tube in every night. So then we introduced the Zen, and it's a phenomenal pressure lowering. We have a fair bit of hypotony because the uveitic hypotenuse and the Zen, we have about a 17%, 17% of interventional hypotony rate that we need to intervene. But the final IOP outcome was actually pretty good in terms of complete success, qualified success, and the final IOP were definitely lower than any POAG series. Mind you, the my uveitics are all very well controlled from a uveitis point of view. So actually, they don't need a huge amount of outflow. They have very high pre-op IOP because they've got no outflow. The trabecular network is non-functional. As soon as you put a Zen in, now you're down to inflow-outflow balance. And then they don't make that much aqueous. So often we actually ended up with a pretty decent IOP lowering. And the only worry that I have is the hypotony. The uveitis flare-up is actually amazingly low with the Zen because it's generally quite non-inflammatory. So for me, actually, ironically, that's not a no-go. Same about the pressure flow. The pressure flow in the uveitics arguably is a bit better because the hypotony rate is even lower because we don't have paratube leak that you do with the Zen. And I think Keith Barton has published their 3-year results on the uveitic pressure flow. Again, it's pretty impressive, better than POAG, because I think they just don't produce that much aqueous. So ironically, I'm not going to say no, actually, with the Zen and the uveitic. But the insertion, as you've shown before, need to be at the level of the non-pigmented meshwork. And if you insert the Zen too low, but you free that up very well.
It's an interesting case.
That's a very interesting point. Thank you very much.
I think this case highlights an important point, and Leon touched on it, which is that it's very important to identify the cause of failure, because it then allows you to tailor your treatment to the cause. And in this case, if the patient presented with a flat bleb and high pressure, without doing a thorough assessment, it would be very easy to assume that it had scarred down, and you would try to needle that, and ultimately you would not be successful. So by doing the gonioscopy and identifying that there's iris obstructing the Zen, and then doing something to address that obstruction, you've treated the mechanism, which gives you a better result overall. These 3 cases are remarkably similar in that you're using the Zen in sort of rescue situations where previous procedures have been done and failed, or the glaucoma is complex and very advanced. And interestingly, the whole concept behind MIGS was actually to allow the introduction of surgery earlier in the treatment pathway and offer surgery that is safer with a more predictable recovery and less impact on the patient, and try and delay the need for trabeculectomy and tube surgery. But what these cases highlight is that actually MIGS is being used across a much broader indication than was originally intended. And we're getting experience with all kinds of complex and secondary glaucomas. So it's quite interesting to share that experience and knowledge. There was a question on the.
May I just answer one of the questions in the comments? There's a couple.
Yeah. So there was a question about.
Right. So the question was, well, the question is, what was done for the original bleb? I presume that's the first case. Yep. So have that been addressed? Well, in fact, after the Stent, well, we know that the bleb sort of leak intermittently, so it doesn't always leak. But once it stopped leaking, the bleb stopped working. So basically, it was a leak that helps the pressure. So that wasn't very good. So, but after we did the Stent gel implantation that I just shown, that part stopped leaking. So we will take a look at that because we don't want to do any more things on that side. But I agree that that particular part is very cystic. It looks dodgy. Perhaps something has to be done to lower the risk of blebitis in the future. But right now, I think we would try to be more conservative at the moment.
Yeah, actually, it's redirecting aqueous can be a very effective way of treating a leak. So if you've got an anterior conjunctival leak and you needle the bleb and redirect aqueous more posteriorly, the anterior leak can shut down. And I suspect that's what's happened in your case, is that you've shunted aqueous off to another location, so the flow has slowed in the area of the leak and subsequently stopped.
I have no doubt that if you give it a few more months, that whole area, that whole trap will just be flat. The conch will be epithelialized. You won't have a risk of endophthalmitis. That's it, really. And hopefully your Zen will still be draining.
Yeah, hopefully, yeah. Actually, I think Dr. Wang has got another question, right?
Yeah, I have one question right off of the presentation just now. I think currently we have some TM mix hydrous. Yeah, any experience on how about the option of putting a hydrous in uveitic? It get blocked.
In what? In the uveitic?
Yeah. Yes.
So I'm not the big fan of putting devices in the angle in the uvetics, and I do have a fair bit of uveitic practice. Couple of reasons. First of all, most uveitic coming to me are quiet. They are already quiet, but the IOP is very high. So I need to, if I'm going to take them to theater to do something, I need to make sure that it's going to get the pressure down. And canal-based surgery, you are less confident as compared to a filtration operation like a Zen. So that's number one. And also, I think PAS rate is high. PAS, hydrous is quite big. And so I think the PAS rate, that concerns me. And last but not least is the fact that devices, when you put it in the right place, do have a reflux of blood. And for me, the worst combination for a uveitic would be blood. A bit of Helon GV in a uveitic. And then we're going to have some uveitic flare-up. So for me, any uveitic, my number one concern is safety. And uveitis flare-up is a bad thing for me. Hypotony is a bad thing for me. So my choice very much depends on these aspects. So I don't really put a device. I may remove the meshwork, but again, I'll be very careful about what uveitis I may induce and how much hyphema I could get.
I think regarding your comment just now on juvenile open angle glaucoma, besides from using this KDB or any angle debridement, how about this kind of Stent or hydrous? Would it work as well?
Yeah. I think getting it in may be a slightly trickier in terms of getting your landmark right. And again, depending on your pre-op IOP, and I think that I stand Hydrus as a standalone procedure. Evidence is a bit lighter, and I think anecdotally from experience, I think they work well as in conjunction with cataract. While a TM removal procedure like a GAT or a KDB tends to work well as a standalone as well as a combined. So I think standalone procedure for me, TM removal favors the stent. In a combination, when cataract surgery was the most important part, I wanted to deliver an excellent visual outcome, a predictive refractive outcome, then I would tend to put a stent in.
So means likely the amount of trabecular mesh debridement larger, it will give a better outcome, means something like that.
Possibly, but you only need to remove, you only get access to 1 or 2 collector channels, and that will be enough to get your pressure down. You don't need 180 degrees or 360 degrees. So I could just tell you that removing TM in some of the JOAC seems to give you phenomenal pressure lowering, just like some of the Uveitis. You have to pick your case very carefully.
Understand.
So we've got a question for Dr. Chan coming in from Slido. Someone's wondering how many times you can do a revision of the Zen bleb.
Right. Oh, right. So the question was, right, how many times can we revise the Zen bleb? I don't know, actually. I would, it depends on the anatomy again. So if you, I personally, if it is very scar down, it depends. I might have to open up and close it, and hopefully the Zen will be underneath the tenon layers. But it already depends on the morphology of the Zen instead of how many times hard and fast through you can do for bleb revision. So actually, I'd rather ask the comment from Professor Clement and also Leon here. How do you think?
Well,
I don't know the answer either because I don't do it.
Was it like Einstein who says there's only a fool that does the same thing twice? So if it worked really well first time around and it lasted a long time, then I may consider it. I think the much more important point is not about how many times you can revise something. Any surgery that we do, we must think about why it's failed and what your surgery is going to offer. What's your revision surgery is going to offer that's going to make this one work and not the last time. Yes, you're offering more antimetabolite, I'll give you that. But if I revised it really well last time and it failed after a year, then the only extra thing I'm offering is more antimetabolite. Is that going to buy me 10 years or is it just going to buy me another year? Then that's why I don't tend to do things more than once or twice. I do one trap, and if it's failed, then I wouldn't do another one unless my first trap lasted me 25 years. If I revised it once and it failed after 6 months, I wouldn't revise it again. Unless it was clearly blocked by iris, then I go and remove some iris like you did. So it's not straightforward in terms of how many times you can revise something. It's just whether your revision is going to do anything and how you're going to do anything different this time. What you can't stop is people from scarring. If aqueous causes to scar, so if you revised it once and it failed miserably after 6 months, I'm not so sure a second time around is going to be useful. While putting a tube in with a plate is much more robust in fighting against scarring, so you may have a slightly better chance. So I hate doing the same thing twice.
There's another thing, another aspect, relating to your case, Dr. Chan, that we don't think about very often, although Leon may think about this more often because he's done a cornea fellowship, which is the cornea ultimately failing. Now, your case had a cataract operation, they had a trab with mitomycin C, they had multiple needlings with 5FU, they had a Zen with mitomycin C, they had another intraocular procedure to revise the Zen. So it's very likely that this patient's corneal endothelium is not great shape at the moment and is only going to get worse. So you've got to be mindful with the subsequent procedures what potential damage you might be doing to them.
I'm going to add to that, Colin. I think that's a phenomenally good point. Yes, you may not worry too much about endothelium, although you've used a lot of antimetabolite. and the Zen is pretty safe for endothelium. But that this huge amount of antimetabolite will cause you some localized stem cell failure. And that's very underdiagnosed in our glaucoma clinic. And what you typically see is that the patient vision will drop. The cornea looks clear, but when you put some fluorescein on it, you realize that there's a triangular shape at the top coming down that is very irregular epithelium. When you put fluorescein on it, it doesn't stain, but it shows you this swirly irregularity because you've got superior stem cell failure. And what you've got on the cornea is conjunctival epithelium coming down. And then the patient is kind of a bit ruined for life. You can scrape that epithelium back, but because there's a localized stem cell failure, that superior part of the cornea, sometimes coming down to visual axis, is always irregular with the epithelium. So you have to be careful how much mitomycin C we apply. And that's a great point Colin mentioned. And ultimately, you may find you get a pressure of 10, but the vision has dropped 3 lines as a result. And in that case, we didn't win.
Okay, I think we've run out of time, so I'd like to thank Dr. Chen and Dr. Cheng very much for their wonderful presentations, and to Leon for his expert comments and questions on the cases. I think it's been a wonderful session. Thank you.